Hi everyone, so my name is Dr. Shane McKeown. I'm the medical director at Careful. I've been a doctor in the NHS for 7 years, but I eventually left really due to what I felt was a highly frustrating and unproductive work environment. So even when I was maximizing my own potential effort, I didn't really feel like I was having the most impact I could for my patients. And really it just led me to feeling burnt out and really left with an inability to care effectively. And I think unfortunately, we all know that this is something that affects all doctors today within the NHS. Everybody's still weighed down by all these gross inefficiencies. So that's why I joined Careful. I really wanted to make a step change in the way that healthcare collaborates and make a difference, a real difference to the patients I could sense, and also support my fellow clinicians with a platform that really worked. So this is the issue that we are facing today in healthcare. This is the problem. Communication errors have far-reaching consequences for patient, families, and staff. And this is a reality of an inefficient, low productivity healthcare system, as we can see on this slide with these numbers. And these numbers are so large because of this. This is the patient journey. This is all the different types of conversations that happen, all the different handovers of information. And this is how we have so much misinformation and missed information as well. So this is our solution to this very big problem. We want to have accountability for individuals and tasks, not merely just have some form of simple messaging. We want to provide safety and support for clinical handover, not just relying on a simple system like SBAR. And really, we really think it's important to have visibility and consistency across healthcare boundaries, not just within individual teams, such as my own clinical team. So Careful makes the whole patient journey safe. Now, throughout 2023, we're going to be raising £500,000 to take us through this year and to expand on what we've already accomplished and what we hope to accomplish in the future. So we will be taking a license fee for each of our sites that we're operating in. And this is kind of the scale that we've reached so far. You can see we have both NHS, private UK, and wider international clients as well. And this is some of the feedback that we've already received from Maidstone and Tunbridge Wells, where we're operating on a dual site basis within their ITUs and HDUs. So just to quickly take you through these numbers, staff efficiency and time saving, 2/3 thought that we had a really high impact on that. And 3/4 found that within team communication was also high impact as well, which is really great to hear. But best of all was this feedback that we got from one of the consultants who, above and beyond what we were delivering in terms of communication and accountability, really felt that what we were doing was meeting a near universal need and obligation for clinical teams, which is the safe handover of patients. So Careful is an opportunity for a step change in how clinicians collaborate and care for their patients. Thank you.
Hi, thank you so much for that, Shane. I'm Rachel Grimaldi, co-founder and CEO of Card Medic, which is a different kind of communication app for patients and staff, and an anaesthetist at Great Ormond Street Hospital and a winner of last year's Pitchfest. So just had a couple of questions.
Sure.
If that's okay, do cut me off, John, if there's not time. Does this sideline face-to-face handovers?
No, not at all. So it's supposed to be supporting verbal handover. It can supplement with asynchronous handover. So there can be pre-conversations, or for example, within an MDT, people can be reviewing and discussing before the actual event. But it's not supposed to replace what's a valuable thing, which is verbal handover with all the nuance that's associated with that.
Okay. Two other questions. One is this like the Alertive app? I don't know if you know, and just maybe a bit about what your competition might be. And the other is how do you monetize this?
Sure. Rachel, can I just get you to ask one of those and then we'll...
Yeah, sure. Yes. So yeah, just about the competition, is this like Alertive? I'll stick with that one.
So I think what we found when looking at the competition is that people are offering sections of what we can offer, but they're not offering the whole package. So they may offer some communication-based system where people are communicating about tasks, but there's no accountability. Or if there is accountability for those tasks, there's no task management in terms of transfer between teams, or there isn't an audit trail that can be easily followed. So when looking at our competition, we haven't found anyone who's covering the same gamut that we are, essentially.
That's great. Rachel?
Yeah, hey, Sharon.
Hi, Rachel.
So, Rachel Murphy, health tech entrepreneur. So my question was around the license cost, actually, and around the pricing. And so I couldn't deduce from the slides what your pricing model was, but it'd be useful to understand it.
Sure. I'll let DJ step in for this one, just because he knows ins and outs.
To be clear, we're pre-revenue, so anything we tell about pricing is aspirational. That means that we have targeted 2,000 to 5,000 pounds per month, depending on the size of the institution. So somewhere between, I suppose, 25 and 50,000 pounds per year as an annual license, something around that. We think that's reasonable. We may find that we're not back, or we may be able to add additional services onto that in order to earn money through consulting work, which helps people actually do the implementation or integration work as well, because it's not going to be a standalone app, and therefore there will be other elements of value other than just the license. Hope that helps.
Brill, thanks.
Thanks both. Rod.
Hi both. Rod Joyce, Deputy Director of Innovation, NHS England. Mine was going to be hopefully not too big a question. Are there any system dependencies or interoperability dependencies for the system to work, as in it needs an EHR or a particular PAS or something just to make it work? And how does that data then really flow to make the experience better?
Well, maybe if I'll answer half and then DJ can give another half. So this can operate fully independently without integration, which we've already seen within our pilots. It can operate in a way that it's just drawing, for example, demographic data from an EPR, or it can be fully integrated so that there's a back and forth of information as well, so that it can scale in that aspect. I don't know if DJ, you want to add to that?
I think it's really important when you're talking about implementing innovation in organizations. You don't just assume that you plan everything and plan and then have a go live date. What's really great about Careful is that you can do it in a stepwise fashion. So you can do it in one team, and then as the other teams become familiar with the system, you can go. So in MTW, we started with ITU, just purely the doctors. Now the nurses are using it. They're doing it for outreach, chronic pain, and we have plans to go into pediatrics and surgery. What's really nice about it is because you can see the network effect once you start getting more doctors and nurses able to refer to each other, and they're quite keen to use it for hospital at night, and also what they call the pink list, which is the patients that are expected into the hospital that aren't anywhere. They're put on a spreadsheet. I mean, if I just briefly say, one of the things that we're trying to do is to replace spreadsheets, which are unaudited, unsafe, all that stuff. And there are loads of them. There are loads of spreadsheets all over the NHS. We've got a list of patients. So if we start with that and then integrate later, then we'll get the benefits of integration. But right now, there's a bunch of stuff happening on spreadsheets that really ought not to be.
Thanks, DJ. Joe.
Hi guys, Joe Stringer from Octopus Ventures. Lovely to see you both. Sort of linked to Rachel's question around competition. We're seeing a lot of the messaging apps in particular doing pretty well, and in terms of traction, probably making most progress. Notwithstanding, I absolutely understand, it's a different scope, but are you not worried that they will use that position of strength to expand out into clinical handover and the broader scope that you're covering?
I mean, I think part of their speed is the fact that they are simply messaging. So not having to have a chat with the IT team about integration and how that's going to impact on, the 5-year digital pathway that trust have planned out, means that you've got a relatively faster route to market, I would argue. So they will come across the same kind of obstacles once they decide that if they do decide they want to expand into what we're doing, they're then going to still have to have those conversations, questions about information governance, and then so they'll be having to come to that hurdle when they come to it, really.
Yeah. Okay.
Can I add to that? Have I got time for a subsidiary answer? I'm at Arab Health at the moment, and our ambitions are global, and we've had a lot of conversations with people who are in exactly the same position as the NHS in many different parts of the world. But I happen to speak to Pioneer Health, who are based in Sheffield, run by a couple of paediatric surgeons, and they tell me that in Sheffield Children's Hospital, they don't even have a digital emergency department. It's all done the old way with the sheets that you take out, the queuing system using the little bits of things. They have whiteboards with bits of things. Now, the reason they do that is because it's really hard to create a system for ED that I actually don't quite know why they're still in that position, but there is no doubt that we could run an ED. It's definitely got the ability to do an ED. Because you can do filtering of patients in particular statuses. We haven't really talked about the whole patient journey aspect of this, but we could run an ED without any trouble at all. The biggest competition we have is that people think that the existing systems they've got do this.
Yeah.
And that's not from Sheffield Children's, who know that they've got a problem. It's from people like GSTT, who go like, well, we've just spent £200 million on Epic. Of course it does this. Actually, not so much. So anyway, that's the competition landscape is more about, if I may say so, is about inertia rather than about messaging apps taking over where we are. They've got a long way to go to be able to do what we've got.
Okay, thanks.
Okay, thank you. Chris.
Yeah, very, very quickly, because my question was once again largely around kind of competition. Largely, which parts of the NHS are you currently targeting?
In terms of geography or in terms of pathway?
Yeah, pathway.
So, I mean, we are actively looking to be able to prove our function in many different pathways, and that's kind of what our focus is. So, as we've mentioned, MTW is obviously within the acute setting in ITU and then expanding across a hospital. But we have other conversations with other trusts with regards to bringing people from ambulances into ED or from discharge in terms of care of the elderly wards out to care homes, which is, fractured with fax machines and bits of paper and phone calls. So what we are looking for is to be able to prove that we can be effective and have benefit across the whole patient journey from community into hospital and then returning to community, because that's really where a lot of the issues and bottlenecks lie, really.
Yeah, and are there any specific areas where you see the low-hanging fruit?
Well, I mean, my personal interest when I worked clinically was in care of the elderly. And so that's, my viewpoint on that. I'm sure DJ would have lots to say about ED, being an ED doctor.
I might just answer the question with an example, which is that we're speaking to, I'll tell you the name, I don't think it's confidential, it's Withybush Hospital in Haverfordwest. We did a presentation for them and they went, you mean the GPs could see the patients as they went through the hospital and work out when they'd come home? I was like, yep, we can do that. We just basically add a team with a GP surgery on one end and we put the community care setting in the other end, and we can do, because it's all team-based, don't have to be restricted to. So if I was to have if I could wave a magic wand, I'd say we would target the unscheduled acute pathway in a district general and definitely prove you can improve discharge planning, you can improve visibility, you can improve the accountability for task, reduce tasks lost, all the patient safety aspects. So if you say, what are we targeting? In my mind, I'm targeting Withybush and their GP through to community care pathway, because it's an absolute classic of inefficiency and difficulty of siloed information and all that stuff. We're not going to compete with EMIS and System 1. And with the larger hospitals, many of them have other solutions for communicating across the ICB, but many of them don't. And that's what we'd like to show.
Thank you. Rachel, I limited you to 2 questions. Did your question get asked?
Yes, no, you did. I had another one if there was time, but no worries if
Sure.
not. It was just about internationalization. You talked about Arab Health, DJ, and potentially working overseas. I was just interested to know, are you thinking about internationalization? And if so, what markets first and how you might go about that? A big question, so don't worry about a detailed answer, but just your thoughts around it for now.
Given that Shane is our UK medical director, I'm going to jump in first. Is that okay, Shane? So we have a whole bunch, they're my cards, but there's a bunch of people we've spoken to today. India, Morocco, Egypt, Saudi, UAE, loads of people came to our stand this last 4 days. I'm completely exhausted. But if I had we're targeting UAE and India as our first non-UK markets. And we have, the reason for that is somewhat serendipitous. I have a co-founder who's based in Dubai, and we have a CTO who used to be the CIO of Max Healthcare in India, and we have a lot of relationships. So this is a global problem. It's not the UK. We sometimes beat ourselves up that we have problems of all sorts, and actually many of those problems are shared. So we are definitely going abroad. We have some potentially opportunistic things going on in other markets, but those are the two that we're aiming for.
I mean, just as a final use case, I mean, I'm not sure if we can mention them by name, but the SOS company we're in discussion with, recovering people from overseas and repatriating them to the UK. I mean, that's an exceptionally complicated pathway, which has language barriers, reams of paper that are photocopied and sent across and kept in a helicopter, etc. So having our system on each end is something that we're very interested in.
That's great. I'm going to have to draw you to a close then. Thanks very much, Shane and DJ. Thanks to our judges. Lots of good questions.
Hello, everyone. My name is Araxi Boyadjan, and I'm one of the founders of Lavender Health. As you have made detected by the flattery and the accent, I am Lebanese. I'll be talking to you about Lavender Health and how we're reimagining LGBTQ healthcare. Let me start by painting a little bit of a picture here. Globally, millions of LGBTQ individuals face large barriers to receiving care and yet are the least catered to. Today, more specifically, I'll be talking to you about barriers to accessing HIV prevention drugs in England. New HIV diagnoses have risen in England for the first time in over a decade. More particularly, for gay and bisexual men who have sex with men, the lifetime cost associated with HIV in 2021 is up to 291 million. We are heading way off course from reducing HIV new transmissions to zero by 2030. And one of our best tools to prevent HIV transmissions is PrEP. For those who don't know, PrEP is also known as pre-exposure prophylaxis, which is a pill that can be taken on a daily basis in order to reduce the risks of HIV. Currently, the only way to access this medication, is through free face-to-face appointments at the level 3 sexual health clinic across the UK. However, significant underfunding of the public health sector has made this extremely difficult, and in current days, the activity has been reduced by up to 90% in some regions, according to BASH, so the British Association of Sexual Health. The most recent report, Not Prepared, pun intended, has highlighted that 65% of individuals are currently unable to access PrEP, and up to 60% of them are waiting longer than 12 weeks for an appointment. And almost half of the sexual health clinics across the country feel inadequate to meet demand. More specifically, how do we know this? We've spoken to over 800 LGBTQ users and everybody involved in the sexual health space, and really honed in on what is the key problem that we are here to solve. In order to meet the demand, immediate change needs to happen, and this is where Lavender comes in. By delivering the Lavender service for over 12 months, we can prevent a very conservative figure of about 20 novel transmissions, for example, which can save up to £16.1 million for lifetime HIV care alone. So what is Lavender? It's a sexual health clinic platform offering sexual health services enabled by queer specialists to offer in-app care. Our mission is to allow queer individuals to safely explore their identities and sexually thrive, all while redefining family. I'm going to show you our product in a bit more detail. So our product is in two parts. So the first one is the patient mobile app, in which individuals can remote test for free, have a free video consultation, and get discreet PrEP delivery to their doorstep, and a clinician dashboard in which a Lavender clinician is able to asynchronously see the data, support individuals with their process, and go through the flow in a very efficient way, unlike the current system that exists. We collect valuable patient insights through our specialized service user questionnaires to save on appointment time. And the metrics that we are recording during our pilot at the moment is the NPS score, the customer satisfaction, the reduction in consultation time, and overall the likelihood of an individual switching to a Lavender service from an in-person service. We can estimate a cost saving for the NHS per patient, as we will be charging £85 per patient. The current tariff for a PrEP new individual will be around £250. And I'm happy to dive into more details in terms of how those costings come into effect. This is by no means where we're going to stop. We are looking to expand our services into well-being, trans care, and family planning. This is just the beginning, but we want to make sure that our services reflect the community's needs, as well as are able to provide the protection that is necessary in order for us to continue thriving. Thank you.
Brill, thanks. Hey, Araxi, I'm Rachel, health tech entrepreneur. So couple of, quick questions. Firstly, I love the name of the business.
Thank you.
And my questions are around integration with the healthcare system. So what's the plan around sharing this data back into the system? Are you planning to link in through, login, summary care record? What's the thinking?
Okay, that's a very good question. And that's something that we have spent a good amount of time diving deep into. So essentially what Lavender is doing is actually quite novel in the way that we want to integrate within the system. By no means do we want to be separate from it. We want to integrate into the more minute details of the working process in order to make the entire system more efficient. So the main thing to consider is that there's two pathways in order to do this. First of all, local authorities commission level 3 clinics, right? And that's part of the face-to-face care. Where we can come in is that commissioners or local authorities can commission Lavender to work with clinics, or clinics themselves can then commission Lavender in order to do that. Another way we're working is also by linking closely to commissioners in order to understand how we can link into trusts. So at the moment, Lavender is in conversations with Southeast London trusts like GSTT, LGT, and King's. And this gives us a broader understanding of how we can then operate into the funding system. The biggest piece that we are actually organizing isn't more the data that we are collecting, which is the population health metric, but more in line with the PrEP provision. So how can we provide free PrEP at scale? So that's what we're currently working with to understand how that can be funneled into the app. But more is to come, because this is a structure that's never been done before. But there's a lot of keenness from the NHS, which we're very excited to continue to provide.
Bro, all right, thanks.
Thank you. Rachel.
Hi, Araxi, great presentation. I'm Rachel Grimaldi, co-founder and CEO of CardMedic, and an anaesthetist at Great Ormond Street Hospital, and last year's winner of Pitchfest. So I had a few questions, most of which you've answered already, one of which was about verticals. I think this is, a fantastic idea, definitely needed. Just wondering, in the app itself, how are you meeting the needs of people who might speak another language, for example? Accessibility wise?
That's a really good question, and I hope you will be sending me some positive jujus for maybe winning this year's. So the way that the app is supporting more communities is that the way that we have structured our interviews, as well as developed the UX UI platform of the app, is inclusive of not only disabilities but as well languages. So while we were preparing, for example, the UX, the tech team were building an infrastructure in order to create a translation of the app into different languages. I myself am Lebanese Armenian, and I speak 5 languages. So I'm working with the tech team in order to create one-to-one translations of the application once we are opening the app to be live on the App Store. At the moment, it's at a pilot stage. And we're currently also in conversations with Prepster. So they're the leading organization that provide PrEP information to everybody. They're phenomenal. So they also do multilingual leaflets and pamphlets for PrEP. So that's the way that we're going to be making sure that it grows across all languages, disabilities, and is inclusive as possible. Thank you. I feel like I'm in a Miss World pageant and world peace.
Chris, you're next.
Yeah, Chris Sawyer, Innovation Lead, Digital Health from Innovate UK. Yeah, just a question kind of around your business model, how you're looking to. I'm not sure if you're actually selling the service yet or not, but how you're going to sell the service, and also just a little bit. You touched on scalability, so I'd like to hear a little bit more about your plans for scalability.
Yeah, no, that's a very fair question. I think much of what we are developing, like I said, is a completely new structure. But just to give you an idea about the way that the PrEP funding is going to be coming through. So for example, I'll give you the PrEP tariff example. Currently for face-to-face appointments, PrEP includes testing, the consultation, as well as the medication prescription. This trio essentially costs about $250 for an individual who's never had PrEP before, to £235 for somebody who's going to be continuing PrEP. And these are the costs that are incurred by the NHS. What Lavender can do is by cutting down basically the costs of the time of the appointment, by cutting down the efficiency, by increasing the efficiency of the way that we prescribe the PrEP, and by making sure that everything is done at a faster pace, we are able to reduce this rate to £85 per patient, which cumulatively with the price of online testing would sum up to about £100. So the way that we are doing our go-to-market strategy with the PrEP service is that we know that PrEP is a free service at the moment with the NHS. We're starting with PrEP and working with the NHS to deliver it. So we are in conversations with commissioners and trusts to sell the service once the pilot is done. So we gather the metrics, they see the metrics and how much we're reducing all of the health econs that I just mentioned. So for example, I can tell you that currently Lavender's consultation time is 50% less than what face-to-face clinical consultation times are. And this is just like in week 3. And we're continuing to be more and more efficient. So by giving the pilot data, by giving them our pricing, we're quite sure that we can get to the next phase. And I think scalability is going to be dependent on the way that the pilots move around in London and then externally to London. So it's step by step, but we are also working on a well-being piece that will be direct to consumer, but that's like a separate thing that I'm not going to be discussing today.
Thank you. Rod.
Hi there, Rod Joyce, Deputy Director of Innovation, NHS England. My question was kind of on that scaling piece around, as you're, from the PrEP bit, 100% get it, opening up access, it's really great. As you're looking to, grow and offer new services, it was just interesting around the conversations you're having with commissioners around them standing up Me Too products to serve different communities, as opposed to saying, right, our plan is to digitize our primary care offering. We're going to use this to be able to build an additional service next to it for a subset of its population. I understand why, but it's interesting that the conversation you're having, and as you do start to rebalance the care, which is, say, certainly needs happening, there's a risk of that divergence of care and offering happening potentially positively as opposed to negatively as it is at the moment. Just how you're sort of going to manage that with those conversations at commissioner level.
I love this question. So thank you so much for asking it. So the way that we think about it is that by looking firstly, like you said, to the specific community care, that there's LGBTQ care, we're actually equalizing what is currently an unequal system. By looking at the different ethnicities as well as disability needs, we're increasing accessibility to a state that is even more is able to reach even more individuals. The way that we perceive what Lavender is going to offer is that we start today with LGBTQ care, and then the next step would be providing judgment-free care. So like a version of care in which no matter who you are, no matter what community you belong to, straight or not, Lavender will be able to provide the highest level of clinical excellence because we have considered every single body, gender, and sexuality. So the way that we see it, PrEP is just the beginning, but I think the next step is that what we see in populations today, or the tendency of the population, 1 in 3 Gen Z individuals identifies non-heteronormative. We are growing into a world that more and more is fluid in the way that they define their sexuality and themselves. Not to say that people are becoming gayer, but I mean, blessings do happen sometimes. I'm pretty certain that the direction that we're going to be taking with the PrEP, as well as the rest of the services that we offer, will be scalable to more communities. It will just be more efficient in the way that it provides it by being more specific at the start.
Thank you. Any more questions? Joe has recused himself because of a conflict of interest.
I thought I had a friendly face in the crowd. It's okay. It's nice to see you, Joe.
They're all friendly faces, I assure you. So I'd like to come in as a chair of judge with a question. What are the biggest challenges ahead of you to actually achieve what you're trying to do? So aside from kind of money, what's the thing that keeps you awake at night about not being able to realize this goal?
Oh, John. Well, there are many. Contrary to popular belief, there is still a lot of stigma when it comes to an LGBTQ service. So we have received quite a fair share of blockers, let's say, due to what we're trying to develop and what we are trying to build. So I think the biggest thing that I am concerned about is not being able to provide the service because of any blockers that come from the mission of what we're trying to develop more specifically.
Morning, everyone. So I want to talk about pacemakers. 500,000 people in the UK have pacemakers or defibrillators, which are potentially life-saving for heart disease. But like everyone else, about 3 in 4 of us will need an MRI in our lifetimes. The problem is, if you've got a metal box sitting under your skin with a computer and a powerful magnet, they haven't been a good combination. And the medical profession has always said these scans are not possible. And that means patients miss out on cancer care, stroke care, and other life-saving diagnoses that are reliant on MRI. So manufacturers knew this and developed the technology to make it possible about 10 years ago. Myself as a cardiologist implant these day to day, and it's a standard of care. But remarkably, these scans still aren't performed. And that's because they need the heart team, the imaging team, and the physics teams all to work together who don't normally do that. And you need to do that to plan these scans safely to adjust both the MRI and devices. And it needs a lot of time, about 7 experts to plan a scan, 3 hours of planning time, delays of months, and often 10 or more emails just to get the communication of all the details across. So we lead in research, education. We've been addressing this health inequality now for about 5 years. We've shown if you've got a pacemaker or defibrillator, you're about 50 times less likely to be referred for an MRI. You're 50 times less likely to have an MRI if you are referred. We've performed a national survey for the UK, and we only do about 1,000 to 5,000 MRI scans a year, when we should be doing about 50,000. So there's almost a 50-fold under provision. So we've worked together with 9 other professional societies, 2 patient charities, to look at different levels how we can solve this problem. We trained 500 doctors in 70 centers in 7 countries. We've written national guidelines. I'm the first author. We've developed educational leaflets for 50,000 patients. We've supported nurse networks as well, and we've mentored 20 services to set up. What we've done now is we've been awarded and have used life science charity funding from the British Heart Foundation to develop an online referrals platform and referrals management platform. And what we're doing with this is making it easier for referrers to refer, so patients actually get scanned and save time for referrers. We've demonstrated it improves access, increases referral volume, and helps centers meet national targets for cancer and stroke care, and helps save time by planning scans quicker. Organically, we've moved from our own center at Barts Health to 3 other centers in the UK, and helping new and large already existing services. 2 are going through approvals processing. Our goal is to use this platform to support a network throughout the United Kingdom. MRI is only provided in 50 centers at the moment at really small volume. And we then want to use funding we're here today for to support the development of non-cardiac devices, which have the same problems as well. These goals align with NHS cancer care, stroke care as well, providing network service provision. There's a massive regional variation. We've shown that in many centers as well. I'll stop there. Thank you.
Hi there, thank you for the presentation. I'm Rachel Grimaldi, anaesthetist at Great Ormond Street Hospital and co-founder and CEO of Cardmedic and last year's winner of Pitchfest. I just wondered who owns the IP for this?
So the BHF funding, which was Life Sciences Funding for Innovation, was pretty helpful to iron out that. So I work at Barts Health, but a lot of this went in before I worked for Barts Health. So there's a lot of pre-existing IP, but also developed through Barts Charity. So I work with Barts Life Sciences, are happy to create this into a commercial entity and want us to as well. So they're not too interested in that side, but they're supporting us. The BHF as well are happy for us to take this forward, and they want it because we've gone through UCL partners, discussed it with a few people, and it seems to be the only sustainable way to get this out into other centers. We're already working in 3 other places, and we need to make that a bit more sustainable. And I think the way is to ask for some money for it rather than rely on BHF to continue supporting.
So do you own the IP personally, or is it sort of shared between?
It will be through me or licensed through Barts.
Okay, thank you.
Thank you. Next up, Joe.
Hi guys, Joe Stringer from Octopus Ventures. Really interesting problem statement, and frankly, not one I'd particularly thought that much about until I saw your entry. I suppose, apologies for the cliche VC question, but addressable market, notwithstanding its incredibly important problem statement, what is the art of the possible in terms of market size?
So, I mean, like you're getting at, this is a small market compared to probably most goals, but the impact is high for stroke, cancer care, and so forth. So there's 500,000 people with pacemakers and defibrillators in the UK. MRI provision's growing about 15% in the UK. So we model, and we published this as well, we need about 50,000 MRI scans to support these individuals. Of course, the time per scan is quite high for each department, 7 individuals, about 3 hours per scan just to get patients into the scanner. In the US, there's another 5 million patients with devices. In Europe, another 2 million as well. But of course, the market's bigger. We're working with colleagues in Birmingham who actually pediatricians. They have the same problem with other devices as well. I think there's about 1.5 million other relevant active MRI devices. So the problem expands beyond just pacemakers and defibrillators.
Right. Okay, thanks.
Thank you. Chris, I think you had your hand up next. Or you're on mute, Chris.
Yeah, okay. Yeah, sorry about that. Yeah, Joe just asked my question, but I think I can ask something similar. Are you revenue generating at the moment?
No, we're not. We've been fortunate enough to have this BHF Innovations funding and Barts Charity funding. So that has let us grow more than we were anticipating to 3 other centres who've asked us, how do we pay for this? And we've said, you don't need to. But of course, we need to make this sustainable. UCL Partners has been really helpful. That's our local allied health sciences network. And they've helped us define how much we need and who we need to employ to make this scalable, but also sustainable in 5 to 6 centres where I think we'll be in a few months' time. And so I suspect we'll need about 250K for that to create a commercial entity that can take funding from all these other bodies that are using, the NHS Trust that are using the service, and employ the necessary people for it.
Okay, have you identified your pricing model?
At the moment, we're going through a cost-benefit analysis. And what the feeling from discussing with experts who are beyond myself, I'm a clinician, seems to be that it's going to be targeting each individual NHS trust that has a service. We know there's 200 of them, but equally we've had discussions with at least one ICS who are keen to see this as a health inequality problem for their whole region, and so we're working with them to model how beneficial it'll be for them.
Okay, and then you'd have to work through all the procurement and frameworks and all those kind of challenges as well. Yeah. Okay.
Thank you. Rod, did you have a question?
I had 2 questions and they've both been asked. I was trying to figure out what
That's okay.
what else I was going to say.
I see Rachel's got her hand up. Perhaps I can come back to you, Rod.
Hi there. Yeah, I just wondered how you'd educate the staff so they're aware of, because it's so hard to change culture, isn't it? Trying to say, no, we can do. I can imagine it's going to take years to get change people's mindsets to say we can do MRIs with pacemakers?
I mean, Rachel, I've been trying to solve this problem for about 5 to 6 years, and we've made headway. So 5 years ago, we were probably doing a few hundred scans a year in the UK for this population. I mean, that's 50,000 is probably where we need to be. That went up to about 1,000 scans, and these are surveys we've done as clinicians and published about 4 years ago. Then all those interventions I described, education, training 500 clinicians, and supporting and mentoring services, changing policy. You'll see statements out there from the British Cardiac Society, the Royal College of Radiologists, all from our data. And that's slowly changing attitudes. Numbers have gone up to about 4,000 MRI scans a year now. And so it's going up, and we know that because more centers are registering on our web platform to say, hey, we're doing this. But it's still got a long way to go, and we're always too slow to change. And for individual patients who need cancer stroke care, that's too slow.
Hi everyone, I'm the CEO and co-founder of Zio Health, and we've developed point of care testing technology, and we're using that for a therapeutic drug monitoring device. So we can test a range of medications, but our initial medication for market is vancomycin. And so vancomycin is used for patients with sepsis and for prophylactic reasons against MRSA as well. But there's a problem when it comes to vancomycin because it has a very narrow therapeutic range. So if you give too high a dose, it leads to toxicity. And if you give too low a dose, it leads to ineffective drug treatment. In the toxic range, it leads to acute kidney injury, and that causes a reduction in quality of life and can sometimes result in death as well. So only 51% of doses are within the therapeutic range at the moment. And the main reason is due to the excessive lead time between testing and results being available. Also, around 27% are in the toxic range. In the NHS specifically, it's 35%. And this leads to increases in basically costs around 36,000 per patient extra, and increases the hospital stays by 16 days on average. And also anyone who recovers from nephrotoxicity, 40% of those roughly will result in readmissions. So we've developed a device which gives results in 3 to 5 minutes so that you can maintain the doses within therapeutic range. So the value to the NHS is obviously the doses within therapeutic range, which basically improves patient outcomes in terms of nephrotoxicity. So there's a prevention of nephrotoxicity, prevention of treatment failure, and reduced mortality. And when it comes to hospital resources, we can reduce the number of days spent in hospital. There's a reduction of days spent in ICU as well, and also the reduction in 30-day admissions. Also, there's a cost savings. For example, for Zio Health, I suppose if we maintain a 94% margin, we can still save NHS providers around £3,000 per patient. The UK Sepsis Trust has stated that the NHS would save around 196 million per year as well. So our market size is around 2.4 billion in the US and UK. And one of the key things in the UK for policy-driven market drivers is the UK policy, basically. For example, NHS England's aim to obtain faster diagnosis and provide personalized treatments. So we've developed a device. We've successfully completed clinical performance studies in the US, and we've been granted our patents in the UK, in Europe, and the US. And also raised previous rounds, so VC and high net worth / angels. And yeah, finally, the team, there's myself, I'm a medical doctor with an MBA, and there's my co-founder, Shaolin, who has a PhD in several research areas. And we've grown the team over the last 5 years to include further PhDs, as well as business development and a scientific advisory board and engineers. Thank you.
Hi there. Thank you. Rod Joyce, Deputy Director of Innovation, NHS England. It was a practical question. Is this a once and done, or is it ongoing monitoring? So you're trying to find the right range for that particular individual and then prescribing that range for them to maintain that? Or is this a continuous in-hospital, then home monitoring to identify?
So we're basically replacing, in hospital, we're replacing the lab. So we would, on average, throughout a treatment course for a patient, would test around 3 times at the moment.
Okay.
And then obviously we would improve that based on the more data that we obtain from the patient over time in terms of health outcomes. Yeah.
Okay. Understood. That was my only one.
That's fine. Rachel, you're next.
Hi, I'm Rachel Grimaldi, anaesthetist at Great Ormond Street Hospital and co-founder and CEO of CardMedic and winner of Pitchfest last year. So just wondered a bit about, sorry, Joe, in case this might be your question as well, but around the kind of market size, because the number of patients that actually need vancomycin that are septic, as you said in your slide, and clinically is relatively small. It's sort of broad spectrum, and those that are penicillin allergic. So just wondering about, actually how many patients and of those who end up nephrotoxic, how many patients it's actually able to support, and are there therefore any other kind of verticals that you could go into, other drugs you can monitor? I know you've got a few on your list, but just sort of wondering around that side of it, how many patients it will actually support.
Yeah, sure. So when it comes to vancomycin specifically, in the UK, there's around 1 million dosing opportunities based on the number of patients who have been prescribed vancomycin. So there's around 250,000 people who've been prescribed it, and then off that, there's around 1 million opportunities to dose to measure the concentration. However, the largest market is in the US. So 1 in 4 patients are on vancomycin in the US, which basically amounts to about 9 million individuals. And so that's where majority of the market is. Yeah.
And so linked question, Neil, if I may, could you expand into other therapeutics? And if so, what would that entail? And how are you pricing?
Yep. So at the moment, we do have other medications. We for example, tenofovir for compliance, as well as tobramycin or even doxorubicin for chemotherapy. And one of them we have an external study starting soon, and the others we're going to set up external studies. And really for other medications as well, it basically takes around 2 to 3 months to develop a new test. The main reason is because of the way our technology works. We don't need to change a lot of the mechanics in the cartridges. It's really simply just developing a binding molecule which targets that medication.
Thank you. Rachel.
Oh, hi, Neil. Rachel, I am a health tech entrepreneur. My question was around how long would it take actually to develop testing for a different drug. So you've literally just answered that, but I didn't want to show up and not ask anything, so I thought I would come in off mute. Thank you for taking us through that.
Thank you. Chris.
Chris Sawyer, Innovation Lead for Digital Health Innovate UK. My question is about the actual product itself. Is the product actually on the market yet?
No.
And so follow-up question, when do you expect to have the product on the market?
So in the US in 2024. So basically we're going through the FDA process in the US right now.
Okay, so US is your go-to market.
US is our initial market, yeah, but then to be honest, shortly after, we're working with NIHR right now. Shortly after would be the UK.
Right. Okay. Right. Thanks.
Neil, just for clarification, the IP, which is distinct kind of Zio, and the patents that you've had awarded, could you just give a bit more information on that, just to clarify?
Yeah, so they're basically to do with the materials as well as the calibration of the how we basically measure the analyte. And we also actually have 4 more patents, which are around the same area, basically, just linking the calibration to the materials, to the cartridges. Yeah.
And is the calibration where the AI piece comes in on this? I wasn't clear from the entry where the AI piece fitted.
Yes, so that's within the calibration, but also within our software for dosing. So that takes into consideration the patient's background and combines that with our instant results to then give a precise dose.
Brilliant, thank you. I can see Rachel's got a hand up.
Just quickly, how it actually works. You're doing it at the bedside. Are you doing a 12-hour trough level or something like that? And then you're doing repeated levels, or does it tell you then in there what dose to give the patient? How does that actually kind of work if a nurse is doing that test at the point of care?
So right now, because different hospitals are using different techniques, some are using trough levels, some use AUC method, and some actually just use a dosing software from private companies. And so what we've done is our result will just display on the device as well. It can display on a user interface as well and connect to EMRs, but that result can then be pulled and then put into whatever the hospital uses for their dosing calculations. We do have a software, but that is basically entering the market separately to the device itself.
I'm Derval. I am one of the 360 million people worldwide with endometriosis. Endometriosis is a chronic disease. It's where tissue similar to the lining of the uterus forms lesions in other areas of the body and on organs of the body. It causes debilitating pain and it disrupts the entire life of sufferers. Friendo identifies those sufferers at an early entry point. It builds a direct healthcare relationship with them from onset of symptoms through diagnosis, fertility journeys, and beyond. Taking on average 7 to 11 years to diagnose, often a lot longer. My own journey took 18 years to diagnose. Along the way, many misdiagnoses. It affects 1 in 9 people. The global economic burden of it is substantial as a result. Friendo is a multi-platform app for endometriosis patients and those who suspect they have symptoms. With Friendo, users can improve their time to diagnosis and treatment pathways through doctor-patient symptom and pain monitoring. The features of Friendo are a screening survey, an endometriosis tracker that tracks your pain and your cycle and your overall lifestyle, a community with credible resources, and a health profile to help you keep track of your post-operative reports, your blood test results, and organization of yourself. Our traction to date has been entirely organic. We have over 5,000 engaged users. Over 20,000 of those are tracking, so we are gathering real-world data. Our business model is we have a free and a premium model offering in the App Store. Our focus is predominantly on our B2B, where we offer a corporate offering to enterprise and to medical institutions. Through this, we have built, or for this, we have built channel partnerships here in the UK and in Australia, who provide us a pipeline for that B2B model. Of course, we have competitors like everyone. Sora, I'd say, would be our closest competitor here in the UK. However, we don't believe in replacing the relationship between doctor and patient. We believe in supporting it. And also we believe in the strength and the importance of our screening survey, and neither of those are on offer with Sora. We've been building our brand. We have testimonials here particularly from GPs who recommend and refer on Friendo. And we've won some awards, particularly with the Health Service Executive in Ireland and AWS. Our team, predominantly female, as you can see. And our goals are to implement a national endometriosis screening service, to become a clinical trials partner and gather real-world data at the right time, to scale to other conditions like Friendo fertility, to become essentially the go-to endometriosis solution recommended by sufferers, partners, employers worldwide. How would we implement this into the NHS? Well, take for instance Chelsea Westminster Hospital and their endometriosis clinic. Visit one, nurse takes previous surgery, medication, symptoms. All of this information can be gathered in Friendo and can be exported over at that one visit. Visit 2, doctor sees patient to discuss treatment pathways, Friendo's tracker and the resources and the insights can also provide a perfect platform to support this as well. In terms of the whole idea and the objective really is to get the patient back to living a successful and healthy life. We are in the middle of a fundraise. We are raising 750,000 for new market entry, marketing and scaling the solution. Thank you very much.
First judge with his hand up is Rod. Over to you, Rod.
Hey there, well, Rod Joyce, Deputy Director of Innovation, NHS England. I was just trying to square off the 2 bits you said. So at the beginning, you talked a lot about the length of time to diagnosis and the repeated misdiagnosis, but the product is there to help support people from the point of early diagnosis onwards. So how are you trying to? And then you talked about taking the step into the screening service. So at the moment, is the product there for when you first visit the clinic for the first time, saying please start using this product so you can start to record what the symptoms and tracking it? What are you doing to then address that the 18 years of misdiagnosis and challenges that you had? It felt like the problem statement was one thing and the solution is something else at the moment.
Yeah. Thanks for your question. Essentially, really how we see our value is at that GP point. And so basically what we're seeing the most value is from GPs, nurses, when they are first seeing potential onset of symptoms. And they are, they're seeing the system, which is kind of 8-9 months down the track of not getting an MRI or not getting to see a specialist. So they're saying, okay, look, track your symptoms, take our survey, take Friendo's survey, and come back to me and show me what your symptoms have been. So basically, that's where the value really is. The value is really look, historically, I guess people with chronic pain are not always the best historians of their own health as well. So having it in the palm of your hand, being able to export it to a clinician right there and then is extremely useful, and to be able to explain the symptoms is extremely useful. Also, I'm the daughter of a GP, so I can say this, like historically GPs have not been educated in this. They are getting a lot better. So having something there, we are finding something like Friendo is hugely beneficial to them as well. And that's where we do see the real benefit for both areas. So for instance, in the endometriosis clinic in Chelsea Westminster, you get your first visit and by the nurse says, go away, track your symptoms. And by the time you come back and actually see the specialist or the doctor, there's a much better picture there of the overall situation. It's also very valuable in terms of post-op. I mean, certainly when I was, the first idea came to me by my consultant in Australia when he says, do you track your ovulation? And I said, well, no, I don't. Well, actually, when I started, I saw significant pain was 3 days before. I was vomiting 4 days before. And so it's quite broad in terms of what it can offer, both for those who suspect they have symptoms and those who are managing the illness. Thank you.
Rachel.
Brill, thanks, John. High level, Rachel, health tech entrepreneur. So yeah, this one resonates. I think 18 years myself to get a diagnosis, so I can understand the need for it. I guess my question was around the commercials. So you talked about B2B play, but I couldn't quite understand. I mean, I can understand selling into businesses, but what is what's the model around that from what's the cost going to be to them? How's that going to play out?
Yeah, thanks for that question. I know I had, with the 3 minutes, I tried to cut out a little bit. But so the B2B basically is, let's take, for instance, the partnerships that we have done with Endometriosis Foundation UK and Endometriosis Australia. So Endometriosis Australia, we're launching Friendo at Work, Endo at Work. And what that is you know, Credit Suisse say, okay, well, 11% of our staff are affected by this disease. They miss, on average, a third of the month, and that's time off or productivity loss. So that's costing them. That's costing the patient, that's costing the employer. So what we're saying, and what our program does, is the objective is to bring them back. It's to help them get back out of a flare-up, get back after an operation as quickly as possible, communicate to their team or to their line manager, you know, about, okay, look, I really want to keep my job. I want to work. So basically what the program is the premium, they get the premium app, and they get a support program in terms of supporting them to get back to work. As part of that program, it also allows them to bring in their partner or another member of their close network as well.
And sorry, John, one super quick follow on. What does it cost?
It's based, the licenses are based on employees, so a number of users.
Great, thanks.
Rachel.
Hi, thank you for that, Devil. I'm Rachel Grimaldi, co-founder and CEO of CardMedic and winner of last year's Pitchfest, and an NHS anaesthetist at Great Ormond Street Hospital in London. I just have two questions kind of interlinked. I'm just wondering what your product roadmap looks like for the next sort of year or two. I know what your ambition was at the end you mentioned, and maybe linked to that is how much engagement are you getting on the community side from your kind of patients and users? You talked about that community aspect, and that might kind of link into your product roadmap.
Yeah, thanks, Rachel. So first of all, engagement, we're getting, our average is they're tracking at least 5 times a month. Excuse me. And so our tracker is definitely our stickiest. So I guess what we're finding is it's very specific to endometriosis, and we talk about competitors, they are broader. Let's say this is very specific to, and that is important in terms of our long-term goal in terms of utilizing data if we wanted for better treatment pathways. But they are certainly tracking, and that is, as I said, solely organic. We have not put any funds into push notifications, into marketing for that. So within our roadmap, that is certainly our plan. So it is to build out our user base, new market entry. So we are getting a lot of traction on the B2B side in Australia. You know, I'm sure you're probably aware, Australia, well, they've invested 58 million into this just recently. They are really proactive on the disease. So it's our second biggest market behind the UK, which is our first market. Our third biggest market is the US. So we're focusing on that for sure. We have a new feature launch in terms of our roadmap. We have a new feature launch in the next 4 months. And that feature allows the user to nominate their clinician, to nominate their partner, their mother, and to have access to certain aspects of their journey. So I guess it's looking back on my own, I essentially built what I'd hoped I'd had, you know, a long time ago. And that is, you know, when you're in pain and when you're in a flare, you don't want to keep explaining what's going on and telling you, so they can have access to how you're feeling, what you need help with, or just understanding what the disease is about. And okay, they can see when your next operation is. So that's a big feature. It's in terms of our commercial model, it's a virality, and you know, it allows for a bigger consumer play as well. Because
I just want to bring in the next couple of questions.
Yeah,
Joe first, and then Chris.
Yeah, hi, Devil. Joe Stringer from Octopus Ventures. I love the area you're focused. This is So we often look at fertility, but obviously, huge correlation with endo as well. And frankly, it's one of those areas that we're actively looking for a solution. The challenge, though, is a lot of them fall into the tracker. It's the symptom tracking. To Rod's point, is there any way to tackle the upfront diagnosis sooner? I suppose from a sort of competition perspective, a lot of the fertility businesses are now sort of, they've got great traction and they've got huge number of users and momentum, and they're now looking to pivot into endo. I guess it was more of a sort of link to Rod's question. Is there any way you can sort of adjust your strategy to try and get further upstream on diagnosis, including devices maybe?
Yeah, well, it's always been there. It's always been there. Our very first and our probably most important advisor is Dr. Edgar Meccano, and he is a fertility specialist. And the reason he supports this is because 60% of his patients also suffer from endometriosis, and they come to him too late. So really, our focus is our USP really is the screening, and we will evolve on the roadmap. I should have finished and continued there, Rachel, but our roadmap does involve AI, and really what we're seeing, I'm on a task force for the Department of Health in Ireland. What we're seeing is Department of Education and Department of Health want screening within schools, so the difficulty is, we don't have enough endo specialists, right? So really in most countries. So what we've got to do right now is, we look at Teal Health, who just raised 8.8 million for at-home cervical screening. Amazing. I think what's going to happen is we're going to see more at-home screening, because we have to support the medical system where we can. So our roadmap is to develop that further, but I guess it's not to push more onto the medical system when we just don't have, when the specialists are tough. We got to support them as well. And I think, speaking as a patient, I suppose really what we want is support along the way. It's not like we want instant operations and diagnosis. I hope that's a bit of a ramble, but it is absolutely on our roadmap. And it's, for me, speaking from someone who took 18 years, it's very important, screening and diagnosis.
Thanks, Dave. Last question from Chris.
Yeah, very quickly. Chris Sawyer, Innovation Lead Digital Health from Innovate UK. Kind of similar to the business model question. It's kind of looking at B2C, B2B health providers. What do you think is the optimal route to the patient?
From a revenue point of view, or
from the patient? So you being a patient, what would be the optimal route to you?
To service me, to support me. Good question. As a patient, actually through corporate. I think if I look back at my career, I was in KPMG, worked for the Olympics. And I think if I had been supported by my employer, that would have been huge for me.
Okay.
Yeah.
So that's a business decision.
B2B. Yeah.
Okay. All right.
Yeah.
Great. Thanks.
Yeah, well, thanks so much for presenting, taking questions and sharing the kind of vision for Friendo.